Welcome everyone to today's webinar. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Kelly Price is Vice President and Chief of Healthcare Data and Analytics at Datajen. Kelly has been working in healthcare finance for over 20 years. For the last 18 years, Kelly has helped members of the Healthcare Association of New York State understand changes in Medicare's reimbursement systems. As Vice President and Chief of Healthcare Data Analytics at Datajen, a subsidiary of the Healthcare Association of New York State, she works with hospital associations in 47 states and 5 multi-state systems on Medicare and Medicaid reimbursement issues. Kelly started her career with the New York State Department of Health, where she developed managed care rates for the Medicaid program. John Calamares is Senior Healthcare Informatics Analyst at Datajen. He provides data analytics support nationwide to awardees of CMMI bundle payments for care improvement demonstration, participants in the mandatory comprehensive care for joint replacement program, and awardees under the oncology care model. John's focus is streamlining production, developing products, and implementing advanced statistical methods. Prior to joining Datajen, John worked as a graduate assistant for the University at Albany School of Public Health, studying aging in place with nursing home and home health data. John is currently working on a PhD in biostatistics through the University at Albany, SPH, focusing on predictive analysis of multi-categorical outcomes. John received a Bachelor of Science degree in mathematics from the State University of Buffalo and a master degree of biostatistics from the State University of New York at Albany. Kelly, I'll now turn the floor over to you.
All right, thank you very much. Welcome everybody. Appreciate you all making the time to be here, and hope to be providing you with some information you haven't heard before, or at least a different way to look at it. A little bit more about our background. Datajen is a wholly owned subsidiary of the Healthcare Association of New York State, so we come from a trade association background. We do a lot of advocacy. That's our starting point for everything that we do. We are the policy-based analytics back room for 47 state hospital associations across the country and 5 multi-state systems. And to put that in context, if you were to ask a hospital CEO anywhere in the country what was estimated to be the financial impact of the ACA on their hospital, more than 95% of them would be giving you a number that came out of our shop. So we have a pretty broad reach. We hear from a lot of different types of hospitals and providers. We also do payment policy and quality analytics for associations, for other consulting firms, individual hospitals, post-acute providers across the country, showing them their own quality of care and helping them figure out how to move the needle on that. And we are the data partner for over 90 participants in Medicare's voluntary VPCI and OCM programs, and as well as the mandatory CJR program and some MSSP participants. We are in that role. One of the ways that we got involved in this was serving as the data partner for the convened group of VPCI participants under the Association of American Medical Colleges. They're also have an education collaborative for the CJR and OCM programs where there's no formal convener role, but there's still a need for lots of support and education. We're also the data partner for CJR for the Ascension hospitals. And just to give you a sense that we're not just hospital folks, we're doing the VPCI data analytics support for Genesis Healthcare, which is a very large skilled nursing facility chain. So let me get right into it. We're all here because of the triple aim, the idea of reducing costs at the same time that we can improve quality and improve healthcare. And value-based payments is the big thing that folks are looking to help us succeed here. The idea being that when you can align the incentives behind the way providers deliver care and the way payers pay for care, you can make progress in terms of better quality, lower cost. Examples of that are, increasing use of telehealth, things like patient navigators and, CVS minute clinics, the guarantees that certain organizations are giving to folks like Walmart in terms of I will be your center of excellence and I will guarantee a certain outcome for a certain price. These are the kinds of things we're starting to talk about. So we're going to focus on bundled payments, and I'm going to give you a brief background in exactly what that means in the context of the direction that Medicare is taking. Okay. Right now, for the most part, we live in what's called a fee-for-service world, in which every provider involved in the care for a patient submits a bill. And this is sort of a representative example of what might happen if a patient got a major joint replacement, which is the biggest one of these, it's the biggest mandatory program. It is the only mandatory program at the moment. But you would have an initial inpatient stay where the surgery was done. And you'd have some physician visits around there. And the hospital would bill the Centers for Medicare and Medicaid Services and be paid. Each doctor would bill for their visits and be paid. That patient would likely need some sort of post-acute care for rehabilitation in one of many different types of settings, and that post-acute provider would submit their bill. There might be other types of outpatient Part B services, labs, DME, Part B drugs. That patient is hopefully also visiting their doctor on a regular basis, so there are, physician office visits. If something goes wrong, there might be an inpatient readmission. So each one of these things is getting billed to Medicare separately, and they're paying them. And you're looking at a total here of just under $28,000. And the idea being that it's payment for each individual service to each individual provider. In the bundled payment world, what's being done is each of these providers is still providing their care and billing Medicare in the same way that they do now, but CMS is calculating a single target price for this full spectrum of services. And what we're saying is they're calculating an average. They're using a baseline period. They happen to be using 3 years. That seems to be the direction that they're moving in. We're using 3 years for all of the programs that are in place right now as a baseline period. CMS is calculating an average of all of the services that are provided, both in hospitals and across the region, calculating what that average dollar amount is. They're doing things to trend it forward and make some adjustments to ensure better accuracy of those numbers. But the next thing that they're doing is they're ensuring their own savings up front. If your average was $27,650 for all of the services that got provided for major joint replacements in the baseline period, CMS is going to take 3% off of the top of that. And they're doing that to calculate a target. So now we've moved from $27,650 down to a target price that's $26,821. So they're ensuring their savings off the top. And what that means, if you think about it, is that if you continue to do the same thing that you did in the baseline period and provide services in the same way when your average was $27,650, you're going to come in 3% over the target. The way that this gets applied, the way this actually impacts the responsible provider, and for CJR, the attributed provider is the hospital that performs, that admits the patient for that inpatient stay for the joint replacement. Obviously, it's a physician that actually performs the joint replacement. But CMS is going to, at the end of what they're calling the performance periods, and that what a performance period is varies across the different programs. For CJR, performance periods are annual. So at the end of 2016, CMS is going to wait 3 months, and then they're going to do something that looks very much like this. I've simplified this. I'm not showing you all of what are called the target cells, but I'm just using the ones that are most populous. DRG 470, which are your simpler joint replacements without fractures, so your elective hip and knee surgeries. They're going to tell you how many of those episodes ultimately got attributed to you based on all of the rules. They're going to tell you what your performance period target was for each episode, and the target amount per episode times the number of episodes equals your total performance target for that period. The next thing they're going to do is add up what they actually paid out for those 100 episodes. And in this case, in this example, they paid out $2.2 million for the care provided for these 100 episodes. That's $200,000 lower than the performance target. But then they're going to do the same thing for each of the other 3 cells. I'm only showing you one other cell right now. If there are 10 DRG 469, which are your more complicated cases, if there are 10 DRG 469 without fracture cases, and the target for each one is $40,000. Now you've got a total performance target of $400,000. And in this case, the actual spend, the actual payments that CMS had to send out was higher than that performance target by $150,000. So we came in under target for one DRG. We came in over target for another DRG. CMS is going to net these all together. And what they would say to this hospital is, you came in total $50,000 under your target. So we're going to cut a check back to you for that $50,000. If the total actual performance spend was over that performance target, CMS would turn around and say, okay, hospital, you have to pay us back that $50,000. It's important to understand how reconciliation works. CMS is going to do the first reconciliation of each performance period 3 months after its end. So for this first one coming up, they're going to do that at the end of March. But then, because we all know that claims can continue to come in for a period of time after that first 3 months is over, they're going to do what they call a true-up 12 months later. And at that point, under the CJR rules, the performance target will not have changed, but the actual spend will likely have gone up a little bit. And so you always have to keep that in mind, that first reconciliation amount is likely to change by the final reconciliation, and it's likely to change not for the better. Another thing that can happen, though, is due to catch up in eligibility rules, it's also possible that you can gain or lose a couple of episodes, and so that could affect your overall performance target as well as your performance dollars. But if nothing were to change in the episodes that are attributed to you, this performance target will remain the same from the first to the last reconciliation, but the actual dollars are likely to have gone up. Brief history of how we've gotten where we are. We had the Acute Care Episode Demonstration Program was the first attempt at this. That was quite a while ago. The real first bundles were DRGs. Long time ago, if a patient was admitted to the hospital would total up the charges and submit a bill to CMS. DRGs moved away from that process and said, okay, if you're admitted for a certain type of condition with these following rules, here's the price we're going to pay. And it's probably going to overpay you for some and underpay you for others. And that's exactly the same concept that we're dealing with now that we're in episodes of care, just moving outside of that inpatient hospital stay. The VPCI voluntary demonstration began in the fourth quarter of 2013. And when it started, CMS basically said to the provider community, tell us how you want episodes to be defined. And hospitals were allowed to apply to own the bundles. Post-acute providers could apply to own the bundles, and physicians and physician groups could apply to own the bundles. So this started back in 2011. People submitted their preferred definitions. I want to go at risk for this. here's what I want the rules to be. I want it to be a 30-day period after discharge, or I want it to be another length of stay after discharge. And what CMMI found is that they had too many different definitions, and then there was no way that they could administer the program using those requested definitions. So they came back to the community and said, okay, we heard you. Thanks for doing all that research and paying all those consultants all the money that you did. Here are the rules. Single set of rules for everybody. With just a couple of different options, you could go at risk for 30, 60, or 90 days, but nothing other than those periods of time. The list of what was included and excluded were set down before you, but there was also some flexibility on what were called the risk tracks, how much risk you were willing to take in terms of stop loss. That program's been extended a few times, and I'll talk a little more about that later. CJR is the first mandatory bundle that CMS has implemented. That started on April 1st of 2016 and is really how I'm going to focus most of our comments today. Applies to just applies to a certain number of hospitals in specified metropolitan statistical areas. The oncology care model is a physician-focused bundle that began on July 1st of 2016, and I'll talk in a couple of minutes about the nature of that and how much different it is. But what we were very surprised at, I think all of us were very surprised, is just a couple of months ago we got a proposal for a second mandatory bundle, what are called EPMs, which add a couple of DRGs, the hip fracture DRGs, to the CJR participants' requirements. But also move into the area of cardiac care. That was proposed to begin in the middle of 2017. There's been a lot of industry pushback about how quickly that is taking place, and I'll talk in a second about why I think it's appropriate. VPCI saw tremendous interest as time went on, and so CMS allowed a couple of more entry points for folks. And extended the program by 2 years. We're seeing indication that CMS is intending to reopen that program, mostly because the macro rule really puts pressure on CMS to make more advanced alternative payment models available to physicians so that they have an option over what's called the MIPS program. One of the things that's been very interesting to us about the VPCI program, we've been involved since its very infancy, since before there was even data available. So we've been talking to hospitals for 5 years now about this program, even though it didn't start until a bit later than that. But what I call the education cycle, the peeling back the layers of the onion on VPCI, has been fascinating. While I think it sounds to folks on the surface that these programs are fairly simple, okay, I've got a target price and I need to come in underneath it, but the understanding of how I'm going to get under that target and how the data interacts with the payment policy and who needs to be involved, that understanding, even for folks who've been involved in the program since the very beginning, their understanding just continues to deepen over time. We really don't see that stopping. In addition, for many providers, many participants, we're seeing a change in the mix of staff that are assigned to the program, either as the senior leadership realizes that they need to allocate more resources to the program, or they just decide there needs to be a change in structure. We have a lot of changes in the staff that we end up talking to. And we have to constantly remind ourselves, both because of staff change and because of this deepening understanding, we're constantly reminded to go back and revisit the basics on these programs so that nothing gets missed. In the CJR program, again, hospitals only, mandated, and that mandated nature drove a change in the VPCI program that we had been requesting for a very long time, which was the recognition that elective hip and knee procedures are very, very different from emergent hip fracture procedures. And so CMS did turn around after all of the comment on the CJR rules and make available to VPCI participants the option of further splitting their targets so that because really, if you had a VPCI participant whose hip fracture percentage had increased since the baseline period, they were just built in to be set up to fail. The oncology care model, as I told you, it's physician practices only, but there are a lot of academic medical centers who are going into this program that we're working with through the AAMC, because they own the physician practices or are working very, very closely with them. So it's a physician-focused model, where CJR is a 90 days after an acute discharge model. OCM is a 6-month program that starts not with any sort of acute admission, but starts with the administration of chemotherapy. And what we're finding here is that while the risk stratification for CJR and VPCI is pretty darn simple, overly simple, and I'm not saying it's entirely appropriate, the risk stratification that's being employed in the oncology care model is pretty in-depth and pretty sophisticated. And what we're going to see over the next few months is how much that complication, while it's in there for a very good reason, but how much it confuses the setting of strategies and directions. Then the cardiac care model is, again, hospitals only. Hospitals are responsible for repayment or receiving reconciliation payments from CMS. And the way it was written really is to incentivize rapid transfer for procedures. If a hospital that doesn't do CABGs or PCIs sees a patient that admits a patient that needs one of these procedures and has to transfer to another tertiary hospital to do that kind of procedure, there's a built-in disadvantage for those kinds of hospitals. I am almost done here, and then I'm going to turn it over to John. But I, again, wanted to give a picture of, I showed you reconciliation overall, but I want to give you a quick picture of how individual episodes are going to compare to that target. While CMS is going to settle you overall, you have individual episodes. Each bar here is an individual 90-day episode. And the height of the bar is the total spend. The colors within the bar represent the placement of that spend. And you can see there are episodes that come in under that target, episodes that are going to come in over that target. That is always going to be the case. It's a matter of what that overall picture is and how it affects your average. And again, not again, but you can see, and John will point this out in our live demo, that inpatient stay, this dark blue bar at the bottom, because targets are set based on a DRG, that inpatient stay is always going to be the same amount of money. It's a DRG payment, which means that all of the variation is in that post-acute period, and that's where the focus has largely been, even though there have been, lots of hospitals are using the Gainsharing waiver in order to maximize their own margin underneath that DRG payment. Doing so doesn't save CMS any money. CMS is still saving the same amount of money. So targets are headed from in the VPCI program, targets are based on a hospital's own experience. For the mandatory programs, what we're seeing is that CMS is moving from a hospital historical average target trended forward to a census region average target. They didn't go as big as the nation, but they didn't stay as small as the MSA, which is what a lot of folks thought. By year 4 of the program, everybody's target will be set at the regional average. Wage adjustment will be made so that nobody's disadvantaged or advantaged based on their own wage index and the mix across the region. But whether you start out over or under that regional average is very important to your strategies going forward. There's data in the CJR program that comes to participants only, and it comes quarterly. And you really get a look at everybody who's involved in your patient's episodes. And this, for many, many participants, is the first time they've been able to see what's happening outside of their walls. And what John is going to show you now is how hospitals are looking at that data and using it to drive their success in these programs.
Thank you, Kelly. Good afternoon, folks. So as you can see here, This is our web-based platform powered by information builders. A little about our platform. It's the information builder software that we've used. It's fun to play around with. It's very secure. There's a lot of functionality we've built into it, and it's frankly nice to look at. Just a quick minute of functionality and the functionalities. On the left-hand side, you will see filters. You can filter on the hospital, the DRG, fracture, etc. Once we apply the filters, they will be applied to every page. So when I move from page to page, they will be filtered. We'll have the same filters pass through. Also, if you notice, when I move my mouse around, move the cursor, you'll see a pointer finger. That signifies that it can drill down to that point. So every chart has that drill down capability where we can drill down and look at the episodes for that point. So 2013 Q3 for DRG 470, that would be all the episodes for that time period. And then we can even go down further to look at the claim detail for that episode. So this dashboard, the episode summary, it gives a hospital an overlook of how well they're doing in the CJR program and gives them a few high-level metrics. So the first thing I'm going to focus on is the episode count. So if you remember back in the good old days of your Stats 101 class about sample size and reliability, when you have a low sample size, all of your metrics won't be reliable, and you cannot depend on them. As you notice, DRG 469 for this hospital, they're very low, less than 10 or less throughout the whole time period. So this is important to when you look at metrics. So for example, looking at readmission rate, if you look at for DRG 469, if you look at one quarter's readmission rate could be 100%, and then next quarter can be 0%. Well, that just could be due to the fact that the first quarter had 2 patients, both of them get readmitted, and the next quarter only had 1 patient and it didn't get readmitted. So to pay attention to the sample size and how many patients for that particular stratification you are looking at. With that being said, I'm going to filter down to DRG 470 non-fracture. This is your elective hip and knees. This is the highest volume, where your highest volume of patients will sit in this category. So the first chart that hospitals might look at to see how financially well they're doing is this episode net average payment versus target. So Kelly mentioned about the target. It will be based off of the region, and that is the blue line, and the red line is the average net episode payment for that hospital. Now, this is not just the sum of all the claims in that episode. It has a little extra tweak to it in the sense of it has a ceiling price for outliers. So that ceiling price for outliers is based off of 2 standard deviations from the regional average. So if the 2 standard deviations away from the regional average is for DRG 470 non-fracture is, say, $50,000, and a patient's episode came out to be, at the end of the episode, Medicare adds up all the bills, and it's at $90,000. At the time of reconciliation, where it's financially appropriate, CMS will only consider that episode to be at $50,000. So there is a ceiling price an episode can be at. Also to note that this right now we're looking at 2012 Q1 to 2014 Q4, and this is the baseline period. So this is looking at a hospital to see how well they would do in the program if they did not implement any interventions or project planning or do any gain sharing, to see how well they would do just right out of the box. As you can see, this hospital, their average net episode payment is higher than the target amount for almost every quarter, which means that if the hospital did not do any interventions, they will more than likely have to pay CMS at reconciliation. So that means that the difference between the payment amount and the target amount, the hospital will be responsible for that amount. At this last 2016 quarter two, this is the performance period data. We actually are just loading currently the quarter three data. So this is actually in performance, the performance period time. You notice that the red line drops off. This is because we are only getting episodes and their claims that start from April 1st, 2016 to June 30th, 2016. So many of those claims have not been completed. They have not finished, didn't do their 90 days afterwards. And for example, if a claim started, say, June 1st, we will only have their anchor stay and possibly maybe a SNF claim or home health claim after where the patient gets discharged. So there's still the rest of the episode. Also to note that we've also created a filter called completed episodes, and this is not just seeing that the episode was completed for the 90 days. We are also looking at, we are considering complete after the 90 days plus another 60 days, because if that person gets admitted to the hospital or starts home health on day 89, that claim won't get to Medicare for a few weeks or a month. So that's where we know that due to the claim run out. But we know that the episode is quote unquote truly complete. So other metrics to look at, hospitals may look at, is the percent discharge to home with or without home health. This is particularly useful for looking at elective hip and knees, because most of the time the patient would want to go home. That not every patient should go home, because every patient is unique and some of them do need to go to SNF care or inpatient rehab. But since these patients are electives, this is an opportunity for physicians or the planning process to optimize that patient for the surgery, so that comorbid conditions can be handled before the surgery, so they would have a better outcome afterwards. Another metric that typically most hospitals don't have to worry about with major joint replacements is readmission rates. Normally, hospitals will have a readmission rate under 10%, but when you do have a high readmission rate like this hospital, then it can be a target for intervention. It's something for the hospital to focus on to figure out why these patients are getting readmitted, and I'll get into that a little bit later. The last graph I'm going to show is the episode composition. Kelly showed this a little bit ago. That's my favorite one to blow up because it does the wave. So here, every bar represents a patient or an episode. The height of the bar is how much the episode costs, and each setting is represented by a certain color. Green being SNF, yellow being home health, red being readmissions, and purple professionals, etc. The first thing, like Kelly said, on the inpatient index admit, they're all about the same across the board, meaning that your variation in cost is really due to the post-acute care. So in this graph, you can see, you kind of get a sense of the hospital's distribution of that post-acute care. This hospital is doing pretty good. On the left-hand side, the majority of their patients are going home with just self-care or with some home health. On the right-hand side, you see SNF, a little bit of inpatient rehab, some readmissions. This is typical because, like I said before, every patient is unique, and some patients do need to go to these facilities. Sometimes we see hospitals that have either SNF or inpatient rehab, so green bars all the way down to the left-hand side. So meaning that almost every patient goes to SNF or inpatient rehab. This can be a opportunity to evaluate their discharge planning process. The SNF or inpatient rehab could be owned by the hospital. It could be just in the backyard of where they got the surgery, thinking that they should just go there. So this is again an opportunity to figure out why that's happening. For this hospital in particular, we noticed that the SNF bars are relatively higher than they should be. So the next page we'll go to is the PAC summary to figure out why that's happening. So here, the first thing I'm going to point out is you see their SNF and home health utilization during an episode is about equal. If this was perhaps 2 years in or even a year into the CGR program and they were trying to target their post-acute discharges, you would want to see that the SNF utilization start decreasing while home health start increasing. But particularly for this SNF and this baseline period to understand what's going on, we look at the days or visits per episode. And we notice that every quarter, their SNF average length of stay is above 21. This is particularly unusual in the sense that Medicare will pay, the co-pays for Medicare will kick in after 21 days of a SNF stay. So these SNFs are holding their patients even longer than that. So now it's a question of which SNFs are the doctors discharging or the hospitals discharging these patients to. And that's where we can go to the PAC provider summary. Here we can see exactly the provider and how many episodes that provider is getting from these hospitals, the total payments that's costing the hospital, I guess, well, Medicare, the average payment per the episodes that go there, days or visits, average days or visits per episode, the cost per unit, which is a surrogate for RUG payments for the SNF, and direct readmissions. This will be important to look at. I just filtered down to skilled nursing facilities. Direct readmissions are important to look at for the case of the quality of that SNF. So if a SNF, even if a SNF has a low length of stay, and the direct readmissions were, say, in this case it was 10, so the majority of patients, even though it's a low length of stay and it's a cheap average payment for that episode, they may be getting readmitted. So that's something to look at for a SNF. Also, we've included star rating, which is useful if you're trying to pick out preferred network of providers. The star rating is useful for the SNF waiver, which allows the hospital, or Medicare will pay for the SNF stay if a SNF has a 3 or higher star rating and the length of stay at the hospital is less than 3 days. So if you want to discharge the patient early, they need to go to a SNF with a star rating 3 or higher so that Medicare will actually pay for that SNF stay. So looking at this hospital's average day per visit, so looking at the days per visit or average visits per episode, you see the top 4 providers all have average day per episode being larger than 21, 24, 30, 22, 30, 36. So the question is why are these SNFs being have such a high length of stay? This is where Gainsharing may be useful, appropriate for hospitals to gain share with these SNFs to bring their episodes down lower, or the average length of stay down lower. Also, it may this SNF with only an average length of stay of 9 days. Why they only have a length of stay of 9 days? They could be a more preferred provider to discharge the patients to. So another question to think about is, or hospitals might think about, is what physicians are discharging their patients to these providers. So we would go to the physician summary, and right off the bat, it's going to look a little messy because we have every physician. I'm going to filter down to the top 3 physicians, top 3 highest volume physicians. So focusing on the highest volume physician, or else sometimes known as the champion operating physician. Here, most of their patients are actually going to self-care or home health, which is what we want to see. But if you notice the right-hand side, their average net episode payment is higher than the target. So even though most of their patients are going to home, they're losing. The hospital is losing about $500 per episode, and that is mainly due to that chunk of patients going to skilled nursing facility. So this is where talking with the physician and engaging physicians can be appropriate to have them but inform their patients in a way of picking the best skilled nursing facility, or again with the gain sharing with the skilled nursing facility. So if the physician wants to know exactly what's their counts of their first post-acute providers, of who they're sending it to, we can go to the episode sandbox. And here we've given the ability for our users to create reports that are not already pre-created, that we've created. So that gives them a different view or a different slice, a different angle of the data that they may need. So these reports, I'm going to create a report where I'm looking at the first post-acute provider type, looking at the actual provider name, leaving episode count, and I'm just going to filter on that high volume physician or the champion physician. I'm just going to run it, and it'll create this report. And as you can see, for the SNF first post-acute provider, the two highest providers, they happen to be the 2 highest providers for the whole hospital. And that kind of makes sense because what this physician is doing is driving, this is the highest volume, so they're driving the numbers for this. What also we can do, or we gave our client the ability to, we've included the claim HIC number, which is their beneficiary ID, so that they can actually look up in their own records what was happening with this patient, why these patients were discharged there, because they can look in their own system. The claims data can only go so far. They can see what's going on, what's happening. The hospital has to do some of its own digging to see why it's going on, because we don't get the discharge. We don't get the discharge data. We're not hooked up to the EMRs. So this is where we give the information, enough information for hospitals to look at, to be able to go on their own and talk amongst themselves to figure out what's going on. So here I actually exported this. You can export into Excel, which clients can be more comfortable with to create their own reports in Excel or create their own measures. It has the same type of capabilities as Excel capabilities. I'm just going to filter down to SNF, the highest volume, and a hospital can go in, and these are obviously dummy identifiers, but they can go in and look up each of these patients in their own records, internal records. So going back to what I was talking about, the readmissions. So since we know this hospital has a high readmission rate, we can go to the Readmit Summary. Here you can look at kind of what's their readmission categories, what are they getting readmitted for, particularly looking at the readmission count by time since discharge. Here, it's particularly concerning with readmissions in the first 1 to 7 days. These potentially could be preventable, so we can drill down into that and look at the claims. This is where medical knowledge and physician engagement understand why this patient got readmitted. Is being readmitted within a week for septicemia, is that appropriate? This is a discussion among your own team. We are not physicians. We can show you the data and cut the data whatever you like, but the context of clinically relevant for that patient, that is on the hospital's hands and the doctors. So you can see why they got readmitted. You can also tell where they get readmitted. So is it at the same hospital? Is it actually at a different facility they're getting readmitted? So these are all useful tools to understand what's going on with the patient and the patient's care. So I know I went through that pretty quickly.
Great. No, I think that's our formal portion of the presentation, and we left a little time. I know there are a lot of questions, so we're going to turn it over for questions.
Great, and thanks Kelly and John for that fantastic presentation. Like Kelly said, we will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So a lot of questions have already come through, so we'll go ahead and jump in with those. And this first question for Kelly and John is, do you have any estimations on joint replacements in outpatient settings?
So right now, under the Medicare program, these joint replacements are on what's called the inpatient-only list. So while you might do it on a one-day basis, if you want to bill Medicare and get paid for it, it gets paid under the outpatient system. CMS did actually, though, ask for comment in the EPM rule, or maybe it was in the inpatient rule, on the possibility of moving perhaps one of the HIP procedure codes off of the inpatient-only list, and specifically asked for comment on how that could or would be incorporated into these bundled payment programs. So it's not an issue yet, at least not for Medicare. It would be on a commercial side, but it promises to become a complication.
Thank you, Kelly, for clarifying that. And moving on to the next question, this is for Kelly or John as well. It is Georgia Republican Congressman Tom Price's bill proposes to delay and suspend implementation of a comprehensive care for joint replacement payment model for episode-based payment for lower extremity joint replacement in a budget-neutral manner. What do you believe will be the impact of this legislation on not only the future of CJR, but the future of bundles in general in the new administration?
Well, we've certainly been having this conversation internally as part of an association, and I'm not really sure that they'll be successful in rolling back the mandatory programs. It's possible, but I think some of that will depend on how much savings they've seen to date. What they will do, if they are successful, is I think they will continue to expand the voluntary programs. The issue there, though, is when you produce a voluntary program, the only people that you're going to get are the ones who are going to save money, and you're going to increase costs for Medicare that way. So that's something I think the administration really needs to think about very hard and understand the difference between who's going to volunteer for a voluntary program versus the incentives when you have a mandatory program.
Well, thank you, Kelly. And this next audience member wants to know, or is asking, can you explain how the entity that owns the bundle, for example, the hospital, shares the savings or recoups the losses with the physician providers that were involved?
So there is the option to gain share with the physicians. It is not required. Lots of folks recommend it because you really can't, it's tough to be successful in something like this without a physician champion, and getting the engagement of the remaining physicians is made much easier by something like Gainsharing. If you do decide to do that, I actually got chastised is maybe too strong a word though by one of our hospital trustees who said, Gainsharing sounds good, but you have to remember when you're doing that, you are increasing the compensation of your already among your highest compensated providers. So politically within an organization, that gets sticky. The way it gets done, there are as many different ways to do this as you can imagine. It's a direct contracting issue between the hospital and the physicians and can be constructed in whatever way you want. There are certain constraints around it. It can't be, you can't promise to share a higher percentage because a physician promises to bring you more volume. And quality metrics need to be attached, but there are lots of different ways that folks are going about this. So it's optional. There are many ways to construct it. Happy to have a further conversation about that afterward.
Well, thank you. That's very interesting. And this next audience member wants to know, is the expectation that CMS will still expect hospitals to bill fee-for-service, or will they eventually transition to billing fee-for-outcome and the hospital then manage the variance themselves? Both CMS and the providers will have to come a very long way before that's even a possibility. Most providers are not set up administratively, internally, to administer a single bundle payment that they then distribute out. So I see that as a long time coming. Great. And this next question is about a possible ACA repeal. And the question is, there has been talk of the Affordable Care Act being repealed. While not definite, it's certainly a significant possibility after the recent election. How would that affect the administration of the VPCI and CJR programs? So the VPCI is a voluntary program. I don't think that one's going away, truly. But this is very similar to the question that got asked earlier in terms of which pieces of the ACA do they want to repeal. I think for the most part, folks don't think that the ACA will actually be repealed, but that it will be tweaked in place. And as a savings type of program, maybe the mandatory programs will be the first to go. But what we're hearing is that these healthcare reforms are really like maybe fifth in line in terms of priorities for the new administration behind things like immigration and free trade. Well, thank you, Kelly. And there's still lots of questions coming in, so thank you all very much. This next question is there an expectation that hospitals will need to modify their EMRs and rev cycle systems to be able to manage episode billing rather than encounter-based billing? And this connects very nicely to the question that got answered earlier. That's exactly the kind of thing that would have to happen in order for CMS to move from a continue to pay fee-for-service and then reconcile retrospectively to a we're going to pay the total bundle out and let the hospital administer it. Yeah, there are significant changes that need to happen inside the EMR and other revenue cycle systems within the hospitals before they could do that. So it's huge. I don't understand all of the mechanisms that would need to change inside a hospital, but that's exactly why what we're seeing right now is these retrospectively reconciled bundles. Thank you, Kelly. And the next question is, how do you gain share with a skilled nursing facility specifically?
So again, there are lots of different ways to do this. You can if you want. You don't have to. You can share, and this applies to physicians too. You know, you can agree to share upside only, or you can agree to double-sided risk. There are skilled nursing facilities out there. You know, I mentioned that we work with Genesis Healthcare, and they're very much in the front of this kind of work, proactively going out to talk to hospitals about sharing the risk that the hospital is at. So it's a matter of finding those SNFs that are ready to move into this world. You know, a lot of the folks that we talk to and help with analytics are post-acute providers, even if they're not responsible for the bundle. The post-acute provider world is recognizing that this is what is coming at them, and that they're either going to have to adapt or fade into the dust. So, you know, you can work with a SNF to decide, is it upside only or is it upside downside? You can set targets for length of stay and readmission rates. We have providers who are sending the physicians, sending what they call SNFists directly into the SNF and working very closely with them. But the first step is definitely opening the lines of communication, explaining bundled payments to those SNFs, explaining that if we can't come to some sort of mutually agreeable solution, there may be some volume loss for that SNF. And never forgetting that while you cannot, yes, CMS says you cannot force a patient to go to one SNF versus another, or to go to one setting versus another. There's nothing saying you have to provide a patient with a list of all SNFs in your area alphabetically. You're allowed to rearrange that list and put the ones that you consider to be highest value, highest quality at the top, and say to your patients, these are the SNFs where, you know, you're going to go home more quickly, you're less likely to get readmitted, you'll get better care, you'll be home and on your feet faster. And patients really do listen to their physicians. So I don't think there are many post-acute providers out there who are still thinking, oh, nobody's allowed to steer, and they consider, you know, any recommendation to be steering. So start the conversation, decide what metrics you want to use, and you may have to ease into it.
Well, great, and that's really helpful to understand. And it looks like we have time for at least one more question, and that is there any talk of CMS possibly adding total joint revisions for the CJR program?
Well, there's no talk of it at the moment that we're hearing. They did add the femur fracture DRGs, or they proposed to add the femur fracture DRGs to the CJR program. Revisions, you know, clinically, I don't understand. I don't know well enough what's the difference between a revision and an initial joint replacement to say that the rest of the clinical community would think that's an appropriate add. And I think that's really important for CMS to hear, is that, you know, they wanted to add the fracture DRGs, the hip fracture DRGs, in order to help maximize the volume of the fractures that were falling under the CJR program, and give the hospitals like more of a stake, and give them, if you're going to set a care pathway for fractures, but, you know, it's only saving you, you know, it's only really being applied to a very small percentage of your fractures, adding those DRGs made a lot of sense in terms of now, you know, it's financially worth the resources required to figure out those care pathways. I can't answer actually about the revisions, though.
Well, thank you, Kelly. And that is all the time we have for today. I want to again thank Kelly and John for their excellent presentation, and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us in the future for webinars.
Thank you very much.
Thank you.